Similar sort of strategy for depression. If your life is going nowhere, you see no future for yourself, there's no clear plan for what's going to happen after you leave high school, you're socially isolated and have no friends, no amount of antidepressant is going to make you feel better. So they don't work alone. Antidepressants have to be part of a comprehensive management package that is putting the person's life back on track. Nowadays, we do use SSRIs, and we do that because they are less dangerous in overdose than tricyclic antidepressants, and they have fewer and less severe side effects. But some patients do not respond to SSRIs, and one should not give up, but try a tricyclic antidepressant, taking all the due precautions. And I once had a very able man who I diagnosed with Asperger's, who ran his own business, flew helicopters for fun, and had been chronically depressed, really quite badly depressed, although still able to just about function for about 10 years. And he'd had all of the above, so I put him on an MAOI and sort of crossed my fingers and emphasized not to drink Chianti or eat fava beans, which are no-nos if you're taking these drugs, and blow me down, he got better. So one should really bear in mind that we have really quite a wide range of medication options for depression. OCD is really an extension of anxiety, if we're thinking about it from a pharmacological point of view. CBT is a highly effective intervention, but some people do need to have their anxiety reduced before they can participate in CBT. And one of the problems with CBT for whatever condition in individuals with ASD is they're not very good at keeping it up after the intervention has stopped. And that is a big challenge. We haven't really figured out how to make sure that the benefits persist for years rather than the active period of treatment. Historically, clomipramine, a tricyclic, is still the most effective treatment for OCD. We tend not to use it much nowadays because of the high rates of side effects, but Evelyn Stewart, one of my colleagues, alerted me recently to this combination of clomipramine and fluvoxamine, which is effective because fluvoxamine suppresses the generation of the metabolite of clomipramine that leads to some of the most serious side effects. So a range of therapeutic options there. Can I go on over my time? Because I was delayed. Some patients with ASD do develop psychosis. This can happen in the teenage years, but more often in the early 20s. A very small proportion of those people will turn out to have schizophrenia. Most will usually have a stress-induced psychosis, which you can sort of usually trace back, often precipitated by going to university without all the supports in place that the person needed. Very important to check before you start doing anything that the patient really does have psychosis. So since I've been here, I've seen 2 or 3 inpatients with a diagnosis of schizophrenia where the responsible psychiatrist has started to wonder, I wonder if they also have ASD, which of course they did. And when everyone had adjusted to that, both of the psychiatrists then came around to the idea that they'd never had schizophrenia in the first place. So it might sound daft that schizophrenia can be confused with ASD, but I know it happens in just about every country. And so very important, if you're treating psychosis, to make sure it really is there. The other situation in which it is difficult is if the patient has psychotic thinking that is an extension of one of their autistic obsessional interests. That can then make it very difficult to decide whether this is just the obsession or repetitive interest, or it truly is a psychotic phenomenon. So in managing psychosis, we want to reduce stress in the person's life and social isolation. Nowadays, we generally use atypical antipsychotics, but occasionally there is a place for typical antipsychotics, but both classes of drugs are associated with extrapyramidal symptoms, much less so in the case of atypicals, but they can still occur, and this is one of the reasons why we try to minimize prescribing of these drugs. And of course, as I mentioned earlier, they're associated with weight gain and potentially metabolic syndrome, and in some people an increase in prolactin. So there's quite a lot of things one has to think about if prescribing drugs for psychosis. Bipolar disorder is straightforward because the treatment in ASD is exactly the same as in everybody else. A mood stabilizer, if the person is high, and a mood stabilizer plus an SSRI if their mood is low.